My name is Ken Resnicow, and I'm a professor in the School of Public Health at the University of Michigan and the Rogel Cancer Center. Today, I'd like to give you my take on the core question for this conference. Why do behavior change attempts often fail, and what can we do about it? When I was asked to participate in this conference, it reminded me that we have been asking some of the same questions for almost 30 years. Interesting, while many of the same reasons for why behavioral effects decay are still active, as I'll discuss, advances in both theory and technology provide us with a whole new set of tools that we can bring to bear to address these problems. Let me begin by establishing a few key concepts. These will greatly guide our presentation. First of all, motivation can be thought of as energy. How much energy are you willing to devote to initiate this change? And how much energy are you willing to devote to maintain this change? Next, change energy is a finite, cherished resource which we defend. This defense of change energy can actually manifest itself as ambivalence or resistance. When we are depleted, when we are exhausted, when we are overwhelmed, perhaps due to stress or other factors such as illness, we can become more resistant to change, and our change attempts under these circumstances are less likely to succeed. Now that we've defined motivation as energy, we can begin to describe different types of motivational energy or different qualities of motivational energy. Now, historically, most behavior change interventions have relied on three strategies, or the three F's: fear, facts, and feedback. However, more recent data suggests that these drivers have a relatively short half-life. They're not great sources of motivational energy. As we'll discuss in a few minutes, a stronger and more enduring energy source, one that is associated with better outcomes, entails linking the behavior to one's roles, goals, and values. Let's continue with our motivation energy metaphor. Successful long-term behavior change can be thought of as a state of energy independence. Well, what do we mean? When we do a behavior without the need for discipline, convincing ourselves, or exerting impulse control, the behavior starts to become energy independent. Now, this is the preferred state and is associated with long-term success. Well, let's use the example of substance misuse. During treatment, individuals are generally encouraged to think of themselves as in recovery, not recovered. Now, this is in part because as long as it takes energy, as long as it takes impulse control, the person is not yet energy independent, and they're at risk for relapse. However, if they reach a state where they're no longer attracted to their drug of choice, and they don't inherently have a drive towards that substance, they're approaching energy independence. That is, it doesn't require any energy to resist, any effort. And the same can be said of healthy eating and exercise. When someone begins to intrinsically enjoy physical activity or healthier foods, and it doesn't take psychological effort or convincing, they're approaching energy independence. Habit strength and intrinsic reinforcement drive the behavior rather than willpower or persuasion. Now, we'll come back to this shortly. These concepts are informed by self-determination theory. SDT, developed by DC and Ryan over the last 30 years, is an explanatory model to understand initially who thrives at school and in the workplace. But it turns out it also provides tremendous insight to help understand why many behavior change attempts fail and what we can do about it. SDT delineates several classes or subtypes of motivational quality, particularly controlled and autonomous. Controlled motivation entails doing something for external others, such as a doctor or your spouse, or when you're doing something out of shame or guilt or internal pressure. Conversely, autonomous motivation is volitional, it's meaningful, and it's aligned with your roles, goals, and values. SDT also describes another class of motivation called intrinsic motivation. And this is what we were referring to earlier when we talked about energy independence. This entails doing the behavior because it's naturally reinforcing, because it's enjoyable, pleasurable, novel, or challenging.
According to SDT, there are three elements of high-quality motivation. Volition, it was my decision. Meaning, it's important to me. An optimal challenge, it's in my skill set to do so, and it's just hard enough that if I do it, I feel I've accomplished something. In general, in motivational interviewing, which is an extension of SDT principles, we don't progress to the how phase of counseling until we have this very strong why. Informed by key concepts of SDT, a few years back, some colleagues and I developed the difficulty by motivation matrix, which, as we will see, further informs our answers to the three core questions of today. The matrix starts on the x-axis, which maps behaviors or behavior changes by their degree of difficulty. In other words, how much energy does it take to do the behavior or make the change? On the left is the simplest class of behaviors, called brand switching, while on the right, we see the most difficult behavior challenges, such as addiction, weight control, and chronic disease management. In the middle, we see moderately difficult behaviors, like getting vaccinated or wearing a seatbelt. Even within a domain, for example, physical activity, we could differentiate between adding activity amongst those who are already active and starting activity, that is, going from 0 to 1 for people who are currently inactive, with the one on the right being more difficult than the one on the left. This is brand switching. Here, the behavior already exists, but the goal is to get you to choose our brand, Coke over Pepsi, our shampoo versus their shampoo. It is relatively rare, however, in behavioral medicine and public health. Our behavior changes are much more complex. Brand switching can be achieved with simple nudges like small coupons, text messages, whereas more complex and difficult behavior change generally require more intensive interventions.
Now let's add the y-axis. This captures motivational quality. You can see the self-determination concepts of controlled and autonomous motivation on the upper and lower end. This equates to low quality and high quality motivation. What the model suggests is that if the behavior change is difficult and motivation is low, or even if the behavior change is relatively simple but resistance is high, then we would suggest a more intensive intervention such as motivational interviewing. Alternatively, if the behavior is simple or it's complex but motivation is high, then less intensive and perhaps less expensive interventions like incentives and nudge messaging might be tried first.
So now, let's return to the three core questions of this conference. So why does most behavior change fail? Well, to answer this question, I divided the reasons into three domains: the individual, the intervention, and society.
Let's begin with the person factors. First, one reason interventions often fail is that motivation fades. It moves from the foreground to the background. While someone might be gung-ho in the first few days of a behavior change attempt, that drive can wane, leaving the person more susceptible to their impulses. Number two, energy wanes in part because individuals initiate change from the weak motivational pathway. For example, as we discussed earlier under self-determination theory, that would include the controlled and extrinsic motivational pathways. Another challenge is that for many behaviors, there are persistent, often intense urges pulling the individual towards the risk behavior. For example, substance misuse and diet. For many of these behaviors, even a small slip can derail the person. And this can be exacerbated when operating from an all or nothing perspective, which can lead to abstinence violation syndrome. As we'll come back to later, preparing people for handling lapses is an important, often underemphasized aspect of behavioral treatment. Now let's talk about aspects of interventions that may be contributing to our failure rates. Using the conceptual models we presented earlier, we can view relapse or intervention failure as a lack of energy independence. Thus, our interventions may need greater emphasis on building habit strength and inducing intrinsic motivation. Second, our interventions often ask participants to jump to how too soon. That is, individuals are encouraged prematurely to start their behavior change journey before they've solidified high-quality motivation, which, as we mentioned earlier, entails three elements: volition, meaning, and optimal challenge. And finally, many interventions simply provide insufficient dose and, as we discussed earlier, fail to adequately prepare the individual for lapse. While my talk is focused on largely individual and intervention factors, of course, macro or societal factors also are at play. And although it won't be the focus of the remainder of my talk, it's important to at least acknowledge that availability of substances and poor quality food, the lack of prevention infrastructure, and the fact that prevention services remain understaffed and underpaid, particularly in under-resourced communities, also all contribute to the failure rates of our behavioral interventions. So what can we do about it? What needs to happen for behavior change attempts to be better sustained? Well, I'm going to offer three related suggestions that we'll go into in a little bit of detail. First is the use of ecologic momentary assessment and geolocation. Both of these can provide just-in-time assessments and lead to the delivery of just-in-time messages, delivered right when the behavior is happening or about to happen. Let's take a look at a few geofencing interventions that our lab has developed. Our first geofencing intervention was done in collaboration with a colleague at the School of Pharmacy. The goal was to lower sodium intake amongst individuals with hypertension. We first marked, geocoded, where these folks shopped, where they ate, and where they worked. Then, when they got near one of their stores, the app woke up and asked them what they were shopping for. In this case, the person was shopping for mustard. Well, then the app would recommend various lower sodium options compared to the one that they were interested in. Similarly, when they were eating at a restaurant, in this case Chipotle, the app would wake up and ask them what they were thinking about eating. Depending what item they said they were interested in purchasing, the app would offer a rating of the sodium content of that item. And then the app would give them some feedback after they made their decision. Here we use geofencing to address substance use and firearm behaviors. The user marks locations in their environment where they either carried their gun previously or have had a physical altercation. Then, when the individual comes near that location, a tailored message such as this would pop up. Again, you can feel the just-in-time nature of what geocoding allows us to do. And finally, let's take a look at the Health Kick obesity prevention intervention developed by Dr. Wolford and our team. Here, both the mom and the adolescent are given versions of the app. In this case, the app is asking whether or not mom is there to buy food for her daughter. She is, so the app recommends some foods that are healthier options to buy for her daughter, at this case, McDonald's. And it also encourages mom to help her daughter Keisha achieve her goals of trying to eat healthier next time she eats at a restaurant. Similarly, the app for the teen gives advice of what would be a healthier option. It then asks the user to rate whether or not they achieved their goal. These goals were established in a previous encounter with the app. Then it asks the teen to set a goal for the upcoming week. It then communicates that goal back to the mom who was asked to support her daughter in achieving that goal. Now let's look at another innovation that has tremendous potential to improve the effectiveness of digital interventions. And that is something that we call behavioral inference. This involves detecting the status of someone's behavior or even their emotional state without having to ask them through a survey. You're already familiar with some natural behavioral inference that's going on with your devices. So for example, you're probably aware that your phone is detecting or has the ability to detect your physical activity level and to give you feedback on that. And many of you, while you're driving, have a sensor in your car that, using data about your lane changing and other behaviors, infers that you might be either intoxicated or sleepy. But I'd like to share with you 3 novel examples of behavioral inference that I think have particular promise for behavioral interventions. In this study, the investigators asked whether or not they could estimate drinking behavior by naturally occurring smartphone interaction paradata. And they did so by looking at 30 young adults who had a previous history of heavy drinking. What they found is simply by quantifying how often someone unlocked their phone, they could classify them into one of 3 categories: not drinking, moderate drinking, and heavy drinking. And what they found is people tend to check their smartphones less as their drinking increases. This is screen unlocks per minute. They also found that during moderate drinking episodes, phone interactions are briefer, yet during heavy drinking episodes, phone interactions are longer. And this is interaction seconds. What they also showed is during heavy drinking episodes, typing speed slows down and typing errors increase. Just using these paradata, they were able, with 97% accuracy, able to classify people's drinking behavior. Here, devices were used to help quantify smoking behavior. 2 wearable sensors were provided, one that measured breathing pattern and one that measured wrist movements on a 6-axis accelerometer. Here's what the wrist sensors look like. What they were able to show is during smoking, the hand comes to the mouth and is immediately followed by a deep inhalation. And those breathing and hand patterns are very different than, for example, walking and eating. Here you could see the respiration and accelerometer patterns of those 3 behaviors: smoking, walking, and eating. Of the 32 relapsers, this device was able to detect 28 smoking relapse episodes, and just using the wrist device, 24 of 32 episodes. Mobile sensors can also be used to predict depressive symptoms. In this case, 28 adults carried a mobile phone with specific sensor data acquisition for 2 weeks. They looked at a few outcomes: how much time they spent in the home and how much distance they walked in the community. They also looked at phone usage frequency and phone use duration. What they found is these variables were associated significantly with PHQ-9 scores or depressive symptoms. And to summarize, here's what they found. People with greater depressive symptoms visited fewer locations. People with greater depressive symptoms spent more time at home, and they moved less through space. Let's discuss one other way that we can improve the impact of our digital interventions, and that is through the use of natural language processing. In collaboration with our computer science and engineering program, we've developed several NLP-based agents that will eventually be used to deliver counseling interventions. One of the first tasks was training the agent to recognize high and low empathy counseling encounters. We did so by feeding into the agent 276 motivational interviewing counseling sessions, each rated by the degree of empathy expressed by the counselor in these encounters. And just by looking at the number of words per exchange, we're able to pretty accurately distinguish between low empathy encounters and high empathy encounters. Counselors in low empathy encounters speak more. And counselors in high empathy encounters are better able to match the linguistic vocabulary and style of their patient. Using both content and style components of the encounter, the agent was able to distinguish between high and low empathy encounters with about 80% accuracy. We also coded every exchange by whether or not there was a reflective statement on the part of the counselor or an open-ended question. Here's an example of a question, a simple reflective statement, and a complex reflective statement. And then, using various natural language processing software algorithms, we asked the agent to learn to predict what is a reflection and what is a question. And although these data are somewhat complicated, the gist of it is that the agent was able, with about 80% accuracy, able to distinguish between reflective responses and other types of counselor responses. Now, in theory, these data could be used to give counselors feedback. For example, here's feedback that we could give them about how many reflections they used in the last session and the last couple of weeks and months, or how empathetic they've been in the last session and the last couple of weeks and months. And we could then provide them with additional support and training opportunities, particularly to boost areas where they may be underperforming or their skills may have drifted. Our team, led by Siki Shen, has begun development of an agent that can actually generate accurate reflections based upon spontaneous client statements. In effect, the agent does two things. It looks into a database of previously coded reflective statements and then tries to contextualize what the patient is talking about, and then it tries to pull the best matching reflection, but changes the content to match what the client was talking about. So in this case, the patient says, I had a really hard time sticking to my diet. The agent finds the closest previous exchange where a client said something similar and pulls a reflection that was used and coded as appropriate. Then it tries to use synonym matching to contextualize what the patient said, and then it generates a new reflection combining the reflection pulled from the library and the contextualization input to generate a reasonable response. Then they asked raters to blindly rate the AI-generated reflections compared to what was actually used by clinicians. And in general, in the pink bars, when reflections use both of those techniques, pulling the matched reflection from the library of reflection and contextualizing it based upon synonyms it found for what the client was talking about, the relevance, reflection quality, and overall quality of the conversation was pretty similar in the AI version, that's pink, compared to the ground truth, which is blue. Finally, one last thing about improving the effectiveness of interventions. I think we can use more creative designs to help find out what works for whom. And two examples are SMART trials and reinforcement learning trials. I'm just going to spend a minute on reinforcement learning trials. Reinforcement learning trials allow an intervention to be adapted in real time for each user so that users will get different content, different modality, for example, digital versus human, a different sequence. One may get message A first, then message B. Another group may get B before A, and it can impact the dose of the intervention. Now, you decide short-term which of these things to vary, usually based upon a short-term function. So if we're looking at a smoking cessation app, the short-term function that it might decide on could be intention to quit smoking or barriers to quitting smoking. And the function can also be based on just reducing cost, not necessarily even increasing efficacy. And finally, just a few other ways that I think we can improve the efficacy of behavior change interventions. I think we should continue to explore deeper personalization, so tailoring not just on knowledge, attitude, beliefs, and barriers, but deeper tailoring on personality traits such as your needs for autonomy and your tendency for reactance. And finally, we showed you some wonderful ways that behavioral inference can be used to help measure behavioral status and emotional status and then guide the delivery of just-in-time interventions. But there are many other behaviors for which this might be possible. So for example, we might be able to use naturally occurring sensor data or camera data to estimate dietary intake, medication adherence, maybe with hand movements, and finally things like violence prevention. We might be able to detect that someone's in an angry state. I look forward to your questions and comments.